Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the second lecture of male reproductive system, and today we talk inshallah about tumor of the testes. We talk about tumors of the testes. Tumors of the testes. So concerning this tumors of the testes, we generally talk about the basic concept of tumor. What about basic concepts of testicular tumor? Generally, testicular tumor occurs in young age. It occur in a young age. So it starts from childhood to 40s generally. Some of them or many are highly malignant. And as in the following minutes we'll talk about classification. Germ cell tumors. This account about 90% of all testicular tumors. So all of the testicular tumors, 90% of them are originated from germ cell. It is common, and as you know from your anatomy, there is sometimes the testis when it moves from the back to the scrotum, sometimes it arrests somewhere, either in the abdomen, in the inguinal canal, or elsewhere. So this is we call it undescended testicle. So it is common in undescended testes. So undescended testes are very vulnerable for malignancy, so you have to replace or refix the testes in the scrotum as early as possible. They talk about maximum 3 years or less. So you have to prod the testes to the scrotum as early as possible. So when we talk about classification of this testicular tumor, this is generally divided into two broad categories. We call it, we have two broad categories, and we have a third group also. Either this tumor originated from germ cell, or from a sex cord stromal cell, and we have other types of malignancy. So the germ cell, yes, you saw spermatogonia, primary spermatid, secondary spermatid, elongated spermatid, and sperm. This is the development of primary spermatogonia. So this is from this type of cells, from germ cells, we have also two types of tumors. We have seminomatous and non-seminomatous. And then a seminoma. So either belong to seminoma or non-seminomatous and non-seminomatous. So the seminomatous tumors comprise a very important tumor. This is seminoma. And we have another types we call it spermatocytic seminoma. Spermatocytic seminoma we don't talk about. So the non-seminomatous germ cell tumors, we have embryonal carcinoma, and we have yolk sac tumor, Also, we call it endodermal sinus tumors. We have choriocarcinoma. And we have teratoma. Teratoma you come across last year. So germ cell tumor are either seminoma or non-seminomatous. Non-seminomatous فيها embryonal carcinoma يلصق فيها choriocarcinoma وعندنا التيراتوما. So السكس كورد أو السترومال tumors we have two types of cells. This is interstitial cell, you know. So if this is a seminiferous tubule with spermatogonia here inside, we have here Sertoli cells here called Sertoli cell. Sertoli cell here, and we have outside another cells which secrete androgen. This is nourish Sertoli cell nourish the developing sperm. So here this primary spermatogonia, this is spermatogonia, primary spermatogonia هنا. Secondary spermatogonia is longitis spermatid, and we have a developed sperm here in the middle of this seminiferous tubule. And outside we have cells here. This is called Leydig cells. Leydig cell. So this sex cord and stromal tumor, either Sertoli cell tumor, we have Sertoli cell tumor, and we have Leydig cell tumor. It is, yes, and we have Leydig cell tumors. In the others tumors, we have metastasis to the testes. We have metastasis either from the lung or from melanoma of the skin, also can prostate sometimes, and we have lymphoma. Also, we have lymphoma of the testes. This is generally non-Hodgkin lymphoma. So basically, we classify, to repeat, basically classify testicular tumor either into germ cell tumor, sex cord, and others. Germ cells, we have seminoma and we have non-seminomatous group, and we have stromal or sex cord or stromal cells. We have Sertoli cell and Leydig cell. Others we come across metastasis and lymphoma. So to go back in details for we take seminoma, and we move it to other sheet. So we have seminoma. We have basic concepts about seminoma. We have basic concept. So as we know before, it is derived from germ cell tumor. So it is originated from germ cell tumor. It is a commonest testicular tumor. It occur between 20 and 50 years of age. So it is rare before 20, and it is also rare after 50. So it is between age 20 and 50 years of age. It is very rare before puberty, and it is rare less than 20. The maximum between 20 and 50 years of age. It's also less common or rare after age of 50. After age 50. Majority, about 60%, present in undescended testicle, present in age in undescended testicle. So it is very common in cryptorchid, and testis it is not in its place. So for this reason, it is very important to refix the testis in the scrotum as soon as possible. So if we go to the gross appearance, morphology, we have gross and we have micro. So in gross, if it is in abdomen, it becomes very large. It becomes age very large to be detected. And if it is in scrotum, it can be detected early because the patient will notice the increasing in size. Cut surface, when we cut it into two pieces, so it is potato-like. It looks like potato-like, and it is gray. It looks like potatoes. Either no necrosis or cystic changes. Hemorrhage, very rare. So it's hemorrhage unusual, and hemorrhage in gross, it is unusual. Microscopically, it composed of a rounded cell, So it comprises of rounded cell, polygonal cell, with distinct cell boundaries. يعني كل cells مفصولة من أختها، لكن they come as a syncytium، يكونوا مجموعة. They have nucleus. And they have nucleolus. It is have prominent nucleolus. So it is have prominent nucleolus inside. So this is a cell. This is a large cell. This is nucleus. And this is the blue one, the blue small one. This is nucleolus. This is nucleolus. This is nucleolus. So the cells has a large cell with boundaries from each other. We have nucleus, large nucleus, and we have prominent nucleolus, prominent nucleolus. So if we have another syncytium here with the same character, large nucleus or prominent nucleolus, cell with boundaries like this. In between we have intervening stroma. Here. We have intervening stroma in between. So this is also have prominent nucleolus. And we have in between this syncytium we have many lymphocytes. These are lymphocytes. lymphocytes. So this is a histology. It is composed of sheets. This is a sheet, and this is called sheet or sensation sheet of large round cell with distinct cell boundaries, clear cytoplasm, prominent central nucleolus. The stroma is often infiltrated by lymphoid cell. Sometimes it's called a follicle, and it is a lot of lymphocyte. So this is a microscopical picture of seminoma. So the spread of seminoma, spread of seminoma, it is either direct spread to the adjacent structure, but there is important things here. We have a tough tunica albuginea around the testes, and this will prevent penetration of the tumor to the scrotum. So tunica albuginea, tunica albuginea prevent the tumor from reaching the scrotum. The scrotum. So scrotum. So the tunica albuginea, it hinder or it jeopardize the movement or the invasion of the tumor from the testes to the scrotum. So the tunica albuginea will prevent the direct spread of the tumor from testes to the scrotum or to the scrotal skin. But later on, if the tumor become aggressive, it can breach the tunica albuginea and can it reach the scrotum. But generally, this is very late, yes. So the most important one is spread through lymphatic because it's carcinoma lymphatic. والليمفاتيك بيمشي إلى إيش؟ إلى الريجنال ليمف نود، ودائما بيكون هي الانترنال إلياك، وممكن يمشي لللمبر المكان اللي تكونت فيه التستيس. مكان التستيس يتكون وهي لما تجي نازلة it brings with it it is blood supply, and with the blood supply it brings the lymphatics. It brings إيش؟ the lymphatic. So the origin of the testicular artery and the drainage of the central of the testicular vein will convey with them the lymphatic vessels. So the spread from the testes, it can follow the testicular vein to reach internal iliac or common iliac, sometimes to lumbar or mediastinum lymph node. So the most important one is a lymphatic spread. The most important one spread of seminoma is lymphatic spread. It is most important than direct spread to the adjacent structure, or it takes place before the breaching of the tunica albuginea and reaching the scrotum. So it is very important, the lymphatic. As many carcinoma do, hematogenous spread is rare. Hematogenous spread is rare. Hematogenous spread is very rare in seminoma. This is like any carcinoma, with the exception of prostatic carcinoma, as we said before. So diagnosis, how can we diagnose this? Diagnosis depends largely on clinical. It is empty scrotum with abdominal mass. This is which can give a hint for diagnosis. Enlarged testes, painless enlarged testes in the scrotum also can ring a bell for tumor. So we can do FNA, fine needle aspiration cytology. It is very helpful, and sometimes it can be diagnostic. It can be diagnostic, but the final diagnosis is by 30 minutes or 30 seconds to answer. The final diagnosis of seminoma depends on what? So the final diagnosis depends on histopathology. Depends on ايش؟ histopathology. Depends on histopathology. So the most important أو ال mainstay of diagnosis is histopathology. طبعا زي ما قلنا يا جماعة no tumor treated without histopathology. لازم to do histopathology. التريتمنت and prognosis. treatment and prognosis. طبعا the best treatment is surgery. If you catch the tumor before it is spread, it is well and good, and this is fantastic. Surgery is very good. Surgery. If it is not amenable for surgery, you can do radiotherapy. You can do radiotherapy. Well, it is very sensitive. It is very sensitive for radiation. Seminoa is very sensitive for radiotherapy. وعندها excellent prognosis. وممكن يحصل ايش؟ كيور. ممكن يحصل ايش؟ ممكن يحصل كيور. يعني في excellent prognosis and ممكن يحصل ايش معاها كيور. So if you don't see it in treatment, it is radiosensitive. It is very radiosensitive. The most important one is surgery. This is treatment and prognosis. Prognosis is excellent. وممكن يكون في كيور. يعني في كيور. الكيور لما نقول كلمة كيور معناها الشخص يتشافى أو يتعافى تماما من الكانسر. So this is the first part of this lecture.